This presentation will be used to describe the medical conditions associated with CVI. It's important to recognize that the traditional diagnostics for individuals with CVI are not always terribly useful at identifying or diagnosing CVI. So for example, the MRI, that is brain imaging used often for the population of children who have CVI, can help identify big structural problems or large bleeds in the brain, but it does not reliably confirm or deny the presence of CVI. Another test that many children are offered is the visually evoked potential, or VEP. This is often suggested by a neuro-ophthalmologist or an ophthalmologist. It's used to recognize whether the impulses that kind of go from the eye through the optic nerve reach the occipital cortex. Unfortunately, it also does not really tell us whether or not the child is functioning or processing vision in a very meaningful way. It does not reliably describe whether the child has functional vision or how they see. There also is not a very strong relationship between the results of a VEP and how a child actually uses their vision or can continue to develop their vision. Another example that, is the teller acuity cards. So the striped cards that are used very often for children who are nonverbal or for infants can be, they're based on novelty theory, that the child will look at the most discrepant pattern. So when just a gray card or a plain card is presented and then a bold stripe, the child is obligated to look at the bold stripe. As the stripes become more narrow and as these are randomly assigned in position, the tester watches to see where the child regards which card they regard, knowing that they're most likely to be driven to look at that most discrepant pattern. And when the pattern is no longer able to be discriminated, they've reached their acuity threshold. Well, this test also is not terribly useful for children with CVI because it does not correlate with their functional vision. So an arbitrary acuity number may be derived from that test, but it frequently does not correlate with how the child actually sees functionally. We hope that ultimately the functional MRI or other tests that actually can measure brain function will hold more promise diagnostically. The diagnosis of CVI is made in a specific way. So there are 3 broad diagnostic criteria used to identify CVI. The first one is an eye exam that does not explain the child's profound lack of visual attention. So these are children who have an eye exam that kind of looks one way, but their functional vision does not match that. Usually, the eye exam shows little effect to the eye, possibly strabismus, possibly some optic nerve damage, possibly a small refractive error, but it does not explain how the child's actually using their vision. It is important to have the eye exam, though. There is no question that the eye exam is an important element in this child's diagnostic portrait. The second diagnostic criteria is that children with CVI have a history of some big neurologic condition. That condition can be associated with damage to the brain, a chromosomal difference, some other kind of functional difference like that would be considered metabolic, like mitochondrial disorders. Some big thing has happened to the brain that affects the child's functional vision. Usually that condition is so significant that it results in additional disabilities, but not always. The third is that the child with CVI will also demonstrate the unique visual and behavioral characteristics associated with this diagnosis. Those will be discussed in another set of slides. What I'd like to concentrate on for this condition, or for this presentation, is the unique medical conditions that are associated with CVI. So this slide shows a list of many of those conditions, which include asphyxia, intraventricular hemorrhage, periventricular leukomalacia or PVL, metabolic disorders, stroke, congenital brain malformations, infections, chromosomal disorders, or possibly trauma. We'll talk just a little bit about each of those conditions. I want to, before we actually discuss each of those conditions though, I'd like to share just a thought. And the thought is this. Many educators may feel somewhat intimidated by the language that is inherent to the reports of a child's brain condition. Some of this terminology is new to some of us. Some of us know the terminology but feel uncomfortable trying to interpret this information. And what I would share with you is that it's really critical that we continue our learning along these lines, that these conditions are really such an important red flag for the possibility of CVI that it is critical that we think of them almost as the parallel to the eye conditions that we learn associated with ocular forms of visual impairment. Teachers of the visually impaired take an entire course around the eye and things that can go wrong with the structures or function of the human eye. If we're really going to be proactive and highly professional in understanding children with CVI, it's also important that we have a good understanding of these medical conditions. So the first one we'll talk about is asphyxia. Asphyxia is a condition that can be caused by multiple things. Many things can cause the condition called asphyxia. Asphyxia occurs based on the severity and duration of the event, and the event can be, as I said, from a variety of causes. Sometimes it's associated with things that happen at birth, a difficult birth. It can happen through trauma. It can happen through a variety of ways. But it's identified because the child has decreased oxygen levels and increased levels of carbon dioxide, which can be measured medically when the child is born or in a hospital setting under various circumstances. Some children will be offered the cooling protocol. Their parents will be approached about having whole body cooling to actually reduce the child's body temperature, to reduce their overall metabolic rate so that they have less of a need for oxygen. Their need for oxygen will be decreased relative to their metabolic rate. And that has been shown to have some effect in terms of the severity of the effect of the asphyxia. But asphyxia is still one of the primary causes of CVI. Another cause of CVI is stroke or cerebral vascular accident. This can occur prenatally or it can happen after birth. It can be focal, so it can affect multiple parts of the brain, or can be focal in just one area, so focal or multifocal. Seizures are often the first sign that a child has had a stroke. Many of these babies that have perinatal strokes will actually go to the newborn nursery with the belief that the baby is typical. And then sometime within the first 24 hours, they have a seizure. In 37 out of 51 reported cases in one particular article, no single cause of CVI of stroke could be identified. So sometimes stroke occurs for reasons that the physicians can understand, and other times it is difficult to know why the stroke happened. More boys than girls are affected, and the long-term effect motorically is generally more to the left side effect than right. So this is a picture of a normal MRI. This shows, as you can see at the top of the slide, you see the eyes, and laterally on each side, you'll see where this child's ears are, and you see the structure of the brain is pretty symmetric. This is another slide of a normal MRI. It's a slightly different view, but it is another normal MRI showing how the brain would be expected to look in a newborn. And this slide shows the MRI of a child who had a perinatal stroke. So as you can see that in the lower portion of the slide, you see the child's occipital area. And on the right, and to some extent on the left, you see that there's a darkened area. That darkened area represents the area where this child had a stroke. The physicians that saw this MRI knew almost immediately that this child was very much at risk to have vision difficulties. And this is a picture of a little boy named Connor. And the slide that you just saw of the MRI of the stroke is the slide of Connor's MRI. And here is Connor, who has left hemiplegia and CVI, had some expressive language difficulties, though he talks up a storm now, and has some developmental delays. Connor is now, I think, 16 years old, and he is doing extremely well. He's actually well into phase 3 on the CVI range and is able to use sight words functionally. Another cause of CVI are infections. When we think about infections, we should consider both bacterial and viral forms of infection, including meningitis. Group B strep is an example, and then the TORCH infections. And TORCH is an acronym that stands for toxoplasmosis, rubella, cytomegalovirus, and herpes. It is the C of that TORCH word, or cytomegalovirus, CMV, that is highly associated with CVI. CMV is also associated with hearing disorder as well. So if you read a report and you see that a child has had CMV and they seem to have vision that is not what you would expect, it would be very important to follow that child and complete an assessment. So the question may occur, I know the question certainly occurred to me early on, well, how is it that a child whose injury to their brain or the effect to their brain was not in the occipital lobe, how is it that they can have vision problems when, like a child who has an infection, the damage really occurs somewhere else? So the slide you see now shows a head sonar. That sonar is like a sonogram, but it's taken through the soft spot of the baby's head where the fontanelle has not closed. And they can look through sound waves. It creates a picture, an image of this child's brain. In the center of this image, you see that there is a darkened area, a pattern that almost looks like 2 ovals on the right and 1 in the center. Some people refer to this as kind of like butterfly wings, and I think you'll see that by looking at this slide. There are arrows pointing to some distinctly white areas right outside those ventricles, those dark areas called ventricles. The ventricles are the place where the spinal fluid is made in the brain. And adjacent to those ventricles, run the optic radiations. So if you remember your anatomy and physiology, if you remember images of the brain, you can remember that there are these fibers that run from the lateral geniculate nucleus back to the occipital lobe, and they run right next to the ventricles. In this case, the arrows are pointing to those white areas, which are areas of intracranial calcification that occur because of the infection. The infection caused areas of the brain to be damaged and actually calcified. Those calcifications interfere with, block the delivery of those visual messages through the optic radiations by actually interfering with those optic radiations. So it's important, I think, to recognize that CVI can be caused by not just damage to the occipital area, but the delivery system back to the occipital area as well. There are other conditions where you'll see this same phenomenon, where the occipital area may not have been directly impacted, but the optic radiations which send these messages back to the occipital lobe have been damaged, and this is one of those examples. So I hope that's been helpful, because I think that it's sometimes hard to put these pieces together when we don't quite understand how one thing can be related to the other. I hope that clarified some of that. Another cause of CVI includes structural abnormalities. So you wouldn't really call this damage to the brain, because the brain was simply formed this way. It didn't suffer a particular form of damage, but rather something happened differently in the formation. And some of the structural abnormalities associated with CVI include congenital hydrocephalus. Sometimes there are structural differences in the brain caused by chromosomal differences, and sometimes they're just idiopathic. In other words, there's no known cause, no reason that can be associated with a known medical phenomenon. So this slide shows images of 2 brains in which you see some significant structural differences in the brain. We're going to talk about hydrocephalus in a moment, but I would like to share that we'll talk about two kinds of hydrocephalus in which the same outcome may occur. We'll get to that in just a moment. This slide shows an image of a premature baby. And prematurity in and of itself is not a cause of CVI. Prematurity is a description of the gestational age of a baby when they were born. That's it. Prematurity is a description of an age in which the baby was born before the expected time of gestation at 40 weeks. So this image of a premature baby is not here necessarily to launch into a conversation about prematurity, but rather to remind us that prematurity should not be listed as a cause of CVI. However, there are some associated difficulties. Children who are premature are at greater risk for certain kinds of difficulties. And so rather than saying prematurity is the cause of CVI, we might say something like intraventricular hemorrhage that occurs primarily to premature babies is a cause. Intraventricular hemorrhage occurs in up to 30% of very low birth weight infants. It's graded 1 through 4. And the greatest long-term effects occur to babies who have grades 3 and 4 intraventricular hemorrhage or IVH. IVH can coexist with white matter damage, with asphyxia, with ROP. It can coexist with other things that can happen to premature babies. Most of the infants who do have a brain bleed, IVH, have one that is less severe, graded 1 or 2. Those have little or no long-term difficulties. But the grade 3 and 4 IVH can result in post-hemorrhage hydrocephalus and in long-term disability. So this image shows a normal coronal image of a brain. You see that ventricles in the center of this slide, again, look sort of like butterfly wings. They're curved shapes, and they are similar in shape. They are not swollen. They're not enlarged. Those are normal. In this illustration, which is actually an illustration that's lifted right from my book published by AFB, that it shows 6 drawings of that same image that you saw of the lateral ventricles. And in the top left picture, you see that's a normal image. The ventricles are that almost like T-shaped drawing in the center of the brain. A grade 1 intraventricular hemorrhage you see occurs, there's some bleeding in the germinal matrix, which is right outside the ventricle. A grade 2 has bleeding that goes into the ventricle, but the ventricle size remains the same. There's no swelling and no subsequent damage. In a grade 3 bleed, things change dramatically. Now there is more bleeding, and this picture, the picture in the middle of this slide and to the right, shows a grade 3 IVH. You see that the dark color, or the blood, has now filled the ventricle, causing the ventricle not just to have blood within it, but to actually swell. So think of the ventricle as almost like a balloon with fluid, extra fluid being in it, actually swelling the shape of that ventricle. The swelling of that shape pushes the ventricle into an unusual size, thus pushing against the optic radiations and creating potential damage to those optic radiations. Because the motor fibers also run adjacent to the ventricles, this child is also at risk for cerebral palsy. A grade 4 IVH that you see at the bottom left of this slide is one in which there is such a great deal of bleeding that the blood actually leaves the ventricle and goes into the brain tissue itself. And this child's at the greatest risk for both CVI and cerebral palsy. And finally, the picture that you see at the bottom right, you see ventricles that are, the image shows a swelling of the ventricles, and you see the little dark spot at the bottom of the ventricles where they meet. That part is the place where the spinal fluid leaves the ventricles, circulates around the brain, goes up and circulates through the spinal cord and cushions the brain. spinal fluid continues to be made continuously. There's no turn on, turn off switch for ventricles creating spinal fluid. And if a clot of blood would happen to block those ventricles, the spinal fluid is now trapped in the ventricles and they swell again. This hopefully is a temporary condition called post-hemorrhage hydrocephalus, or if it's a congenital malformation causing that blockage of the ventricles, that's congenital hydrocephalus. And this slide shows some head sonars that just show different levels of intraventricular hemorrhage or IVH. And you can see that these there are 3 images at the top and 2 at the bottom. I will just signify that you can see in the middle picture on the top row, you can see that one of the ventricles is very different size and shape than the other. The third picture, you see significant swelling of those ventricles. The picture at the bottom left, and well, both pictures in the bottom show a grade 4 IVH. And this is actually, for comparison, a normal view of the sagittal or side view of a ventricle. This shows a comparison now of one that is a grade 3 to 4 intraventricular hemorrhage. So I'll just, we may want to flip back and then forward again so you can compare those. Another cause, and a significant cause of CVI, is periventricular leukomalacia, or white matter damage. White matter damage is destruction of white matter in the brain, and it can be in premature infants or in children who have other coexisting conditions of the brain. It can be focal or diffuse, commonly results in spastic diplegia affecting the legs, can occur in utero or after birth, and again is caused by low oxygen or low blood flow to the brain. Periventricular leukomalacia looks like this. If we look at the slide that shows the head sonar, you'll see that in the center of this slide, again, you'll see the small black dark areas that are the ventricles. And to the sort of superior and diagonally from these ventricles, you see many additional black places, which are actually spinal fluid filled holes. These are called cysts. They are white matter damage, and they are areas where brain tissue has died, and they now become fluid filled. One spot, one little area like that would still be called white matter damage or PVL. This child has multiple areas bilaterally. And this is Matthew, and that was his head sonar. That was actually the head sonar of this child that you see. This little boy, this is a picture of him as a preschooler. He is now a high school student. And you also see Matthew has strabismus, but he actually had spastic quadriplegia as a result of his extensive PVL. Metabolic causes are another broad category of causes of CVI. Metabolic causes can include things like hypoglycemia. Hypoglycemia, when it is profound and prolonged, can result in a very specific and very targeted damage to the occipital cortex. If you think about anyone who has a tendency toward low blood sugar, for example, if you think about what happens when your blood sugar begins to really fall, that people report that they begin to see visual disturbances like spots before their eyes or things get blurry. And that's a very minor version of the effect to the occipital cortex that is experienced when hypoglycemia occurs and is severe and prolonged. That this is a very serious condition, an unusual condition, but under the broad category of metabolic causes. So the brain needs 2 things to really survive: glucose and oxygen. The lack of oxygen can result in asphyxia or other conditions that we've talked about. And when the glucose levels really are very atypical, we can see hypoglycemia. 2 other causes that are considered metabolic causes are mitochondrial disorders, which are becoming identified more and more commonly. I think they probably occurred before in history as well, but we're getting, medical scientists are really discovering more refined ways to identify even some very unusual or subtle mitochondrial disorders. And kernicterus. Kernicterus is a condition in which the bilirubin levels in a newborn rise so high, and again, this also must be profound and prolonged, that it crosses the blood-brain barrier and serves as a kind of toxin to the brain, causing significant visual impairment, and also associated with hearing loss. A few words about chromosomal and genetic disorders, another broad category of causes of CVI. These chromosomal and genetic disorders may cause structural differences in the brain. They may cause, as importantly, functional differences in the brain. The chromosomal microarray can provide more information, and we'll talk a little bit about examples of deletions or additions on the P or Q arm of the chromosome. So this slide shows a chromosome, a drawing of a chromosome. You see at the top, the two arms at the top are called the P arms. The two at the bottom are called the Q arms of the chromosome. And you may be familiar with this from looking at some students' records where they may describe that the child had a certain chromosome, like a 13P plus or a 12Q minus. It means that part of the genetic material either was deleted or actually translocated to another chromosome. In either case, that results in abnormal messages that in every cell of that child's body, which may also translate to some disabilities, including possible structural differences in the brain that can be associated with CVI. This slide shows a sample of a human genome, and you see that there are 23 pairs of chromosomes, and that if you look at these chromosomes, you can see that if you line them up one right next to each other, they are the same. And if one seems to be a little bit crooked, just imagine that you could straighten that out. You would lay it on top of the other in the pair, and they would be identical. You see this is a male because this one actually on chromosome 23 is an XY chromosome. This is another example of a sample of chromosomes. And again, in these, you'll see this is also a male. And some of these chromosomes look a little bit crooked, but again, imagine that you can straighten them out and lay them on top of each other. They will be identical unless you look specifically at the pair that is numbered 5. You'll see that there's an arrow pointing to the top of the P arm of this pair, and there is a deletion to that 5th chromosome. That could result in significant and possibly even global effect to the child. That also may result in CVI. And finally, the last broad category of causes of CVI is the category called acquired CVI. So CVI can occur as a congenital condition that occurred at, before, or around the time of birth, and it can also be considered something associated with trauma. So things like auto accidents, shaken baby syndrome, near drowning, near-miss SIDS, gunshot accidents, any trauma in which the brain has been significantly impacted can result in CVI. And we assess kids who have acquired CVI the very same way we do children who have congenital CVI, though the programming may vary slightly because these are children who actually had typical vision for some period of time, but that vision was interrupted by this trauma. So there are some variations, slight variations in the way that we approach them for interventions. Again, I'd just like to share that these medical conditions are the presentation of these conditions are not meant to make us medical experts, but rather to be able to be astute to the formula that kids with CVI will have an eye exam that does not explain the way they see, a history of some big medical condition, and the third is the presence of the characteristics. So in order to really put the profile together appropriately, it's critical that we understand what the cause of CVI originally was. So thank you.